Good afternoon, everybody. Thanks for joining us today in our Pediatrics Grand Rounds. Welcome, Dr. Nadkarni and Dr. Morgan. Thank you for being with us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you to our moderator for this event, Dr. Jaime Aurelio Céspedes, Director of the Pediatric Hospital of La Cardio. Welcome, and thank you for moderating this event.
Thank you, Lorena. Thank you, everyone. Good afternoon, Vinay and Dr. Morgan. Mi nombre es Jaime Aurelio Céspedes, soy el director pediátrico de la Fundación Cardioinfantil y hoy voy a ser el moderador para este evento. Nuevamente, buenas tardes a todos. Les queremos recordar que al conectarse a esta conferencia, autoriza el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 del 2012 y nuestra política de datos personales, la cual pueden consultar en www.cardioinfantil.org. De igual forma, le informamos que esta conferencia está siendo grabada. El chat para preguntas se encuentra habilitado en la barra de participantes y les agradecemos dejar allí sus inquietudes, las cuales resolveremos al final de la sesión. Hoy tenemos el honor de contar con la participación como expositores a los doctores Vinay M y Ryan Morgan, con la conferencia Update in Pediatric Resuscitation Guidelines. Disculpa, ahora voy a cambiar nuevamente a inglés. Dr. Nadkarni, of Maryland School of Medicine. Later on, his residency in pediatrics at the National Children's Hospital Medical Center, followed by the fellowship in pediatric critical care at Children's National Medical Center. Currently, Dr. Nadkarni is board certified in pediatric critical care medicine and in pediatrics, and he is currently the medical director of the Center for Stimulation, Advanced Education, and Innovation at the Children's Hospital in Philadelphia. He will be also joined by Dr. Morgan, who did his medical training at the medical school in New York University School of Medicine. Later on, he did his pediatric training at the Morgan Stanley Children's Hospital at the Columbia University Medical Center, followed by his fellowship in pediatric critical care at the Children's Hospital in Philadelphia. Dr. Morgan is also board certified in pediatrics critical care and in pediatrics, and he is a pediatric critical care physician in the Department of Anesthesiology and Critical Care Medicine at Children's Hospital of Philadelphia. Dr. Nadkarni, thank you again. Pleasure having you again here. The floor is yours.
Well, good morning, good afternoon, and good evening. Greetings from the Children's Hospital of Philadelphia on behalf of myself and Ryan Morgan. We're both faculty at Children's Hospital of Philadelphia, CHOP, and we are really pleased to be here with you to talk about advanced CPR. Now, I have no financial conflicts of interest, although I do have some grants with the NIH, with Zoll, American Heart Association, Laerdal, and RQI partners, Nihon Kohden, and the University of Pennsylvania. And I sit on some volunteer science advisory boards, including the Society of Critical Care Medicine, International Liaison Committee on Resuscitation, and the American Heart Association Get With the Guidelines Resuscitation, and Citizen CPR Foundation boards. But these are volunteer positions, and I will not be endorsing any specific product or technique, but just talking about some on-label and occasional off-label use of current technology. I think we'd all agree that the formula for survival is a product of the medical science quality, the educational efficiency, and local implementation efficiency, the product of which results in our formula for survival and so for survivorship. Now, pediatric resuscitation focuses on the first breath of life and not on the last gasp of death, with frequent drowning, motor vehicle crashes, and apnea bronchiolitis, pneumonia, and shock. But adults are more commonly with cardiac etiologies of arrest due to coronary artery disease. So how do we differ? In the out-of-hospital cardiac arrest environment, about 5 to 10% of arrests are pediatric under the age of 18, with about 1/3 as many shockable rhythms. But survival and favorable neurologic survival are about comparable in terms of percent survival and percent favorable outcome. In the in-hospital cardiac arrest arena, children, again, represent 5 to at most 10% of cardiac arrests, but 93% occur in ICU settings, whereas only a little more than 50% are in the ICU. Many are on the ward for adults. And survival is almost double for children than it is for adults, with good favorable outcome in the majority. So clearly, children are not just little adults. The etiology is different, the outcomes are different, and the developmental scheme is different. And so a separate chain of survival for the in and out of hospital cardiac arrest patient is necessary, with a focus on prevention, early intervention, and high-level care. Thus, basic and advanced life support is somewhat standardized and is appropriate with a focus on ventilation and shock management. In 2020, the updated guidelines around the world, fueled by the ILCOR evidence evaluation process and contextualized by each of the individual resuscitation councils, emphasized that high-quality CPR is the foundation of resuscitation, making sure to have adequate compression rate, compression depth, full chest recoil, minimizing interruptions, and avoiding over-ventilation. Our current guideline targets are to push hard about 1/3 of the anterior-posterior chest depth, approximately 4 centimeters in infants, 5 centimeters in children, and 5 to 6 centimeters in adolescents and adults, pushing fast 100 to 120 times per minute, minimizing interruptions with a chest compression fraction target of greater than 80%, and avoiding overventilation. And in the last round of guidelines in 2020, the target ventilation rate increased from 10 to 20 to 30 breaths per minute in all of the councils. The advanced life support tenets included giving early epinephrine for patients in non-shockable rhythms, improving the likelihood of survival, and similar early shock for shockable rhythms. In terms of airway management, aiming for a ventilation rate of 20 to 30 breaths per minute, with an emphasis on ventilation for young children, and not underestimating bag mask ventilation. Early intubation was not associated with better survival outcomes in in-hospital cardiac arrest. Now, the caveat during COVID was that because of the aerosol generation properties of bag mask ventilation, early intubation by an experienced provider, perhaps with a video laryngoscope, was advocated. In addition, a HEPA filter was added to the expiratory limb of either the bag mask circuit or the ventilatory circuit. In the post-arrest arena, increased attention to seizures and post-cardiac arrest treatment, addressing myocardial dysfunction, maintaining a blood pressure, and paying attention to fever, cooling, and vasoplegia, paying attention to the end organ dysfunction, and treating aggressively with post-cardiac arrest care teams. In the post-cardiac arrest care environment, highly associated with survival and neurologic outcomes was early and persistent hypotension, hypo or hypercapnia, hypo or hyperoxia, and a fever was associated with worse outcome. Continuous EEG monitoring was recommended where available because of the association of electrical status epilepticus or electrical status associated with worse outcome. And a delay in prognostic decisions was advocated until after 72 hours of return to normal temperature after cardiac arrest in order not to give up too soon and too early. A new 6th ring of recovery was added to the 5-ring chain of survival, both for in and out of hospital, with a flashlight aimed at the post-arrest care and recovery outside the hospital and beyond the hospital walls. This left us with just a few key items to focus on during the pre-arrest phase, during cardiac arrest, in the low-flow CPR phase, and in the post-arrest stabilization or recovery phases. Our challenges for goal-directed therapies were the level of evidence and quality of evidence that's undergoing continuous review, and how that was processed and taught, learned, remembered, acted on, and acted on well with quality. And now we are measuring and figuring out if it can work, if it's feasible and safe, does it work, and does it result in better neurologic outcome and quality of life, what really parents and families care about. As we start to move forward, we understood that we had to train the individual on skills, behaviors, and cognitive knowledge. We had to train the team on communication and teamwork using performance feedback. And we had to train the system and the environment using performance debriefing, identifying latent safety threats, and learning by debriefing. Low-dose, high-frequency training or spaced learning became popular not only to achieve skill levels, but to retain those skill levels and teamwork. We discovered that high-quality CPR was associated with survival, and especially with short-term survival. But if we combined it with post-cardiac arrest debriefing of the team and the system, we could start to see improved survival to hospital discharge and a doubling of intact neurologic survival. As we started to gather collaborative institutions from across the world, we began to focus and discover that we could identify the pre-arrest, the arrest, and the post-arrest care targets that we were lagging on and needed assistance to achieve high quality and high performance. And to begin with, we started on the intra-arrest variables, where we knew pushing hard, pushing fast, full release, and maintaining a high compression fraction were previously associated with outcome. We discovered through the collaborative that chest compressions do not often meet the 2015 AHA guidelines for chest compression fraction, rate, and depth, and compliance was poor for both infants and children. When we looked at almost 200,000 real chest compressions during real resuscitations, we discovered that for each 60 seconds of CPR, the compliance for fraction, rate, and depth were poor, only achieving depth targets a third of the time, and that it was particularly poor in the under 1-year-olds, a little better in the 1 to 8-year-olds, and better yet in the 8 to 18-year-olds, but still below the 50% target. And so we had a long road to travel. We started to think that maybe one size does not fit all, but that the principles of assessment, monitoring, feedback, and quality are really all the same. We started to recognize that the apneic newborn, the child with bronchiolitis or apnea or pneumonitis or shock, the child with congenital heart disease and post-op care, and the adolescent with commotio cordis during sport were very different types of cardiac arrest, and they might all need different therapies. But our guidelines and our targets are still sort of one size fits all. And although we recognize that perhaps coronary perfusion pressure, diastolic blood pressure, end-tidal CO2 may be additional targets that we can add when available, we weren't quite sure how to use them. So I'd like to turn over the presentation now to Ryan Morgan, another faculty member at CHOP who has focused his career on goal-directed CPR. And he is now the American Heart Association's chair for the Pediatric Emphasis Panel, the task force focused on pediatric basic and advanced life support. Ryan?
Pleasure having you, Ryan. Welcome.
Thank you, Dr. Nadkarni, and thank you to our hosts for the opportunity to address this audience. For the next 20 minutes or so, I'll build on what Dr. Nadkarni had been speaking about and really dive into this topic of physiology-directed CPR. So I'll start by talking about the background and the logic behind measuring physiology during CPR. We'll specifically discuss diastolic blood pressure and end-tidal CO2, really is the most established means of doing this. We'll talk about some therapeutic strategies in terms of how this can actually be accomplished at the bedside. And then I'll close by talking about some other tools that are on the horizon. I do have some National Institutes of Health grant funding to study this topic, but don't have any other relevant conflicts. And so diving right into it, our current CPR algorithms, as we've just heard, are primarily oriented towards this person, the rescuer, the provider. We teach and train rescuers to push a specific depth at a specific rate, and we measure what they do. The logic behind this is that it's teachable, it's trainable, and it works for the masses. And without a doubt, this model has driven the improvement that we've seen in cardiac arrest outcomes over the last 25 or 30 years. But especially for those of us practicing in well-equipped settings with highly trained teams, we believe it's time to shift the focus to the patient's physiologic response to those actions. So as this person is providing care, what does the patient actually see? What is their coronary perfusion pressure? What happens to their end-tidal CO2? And perhaps what's even happening in their brain? I would love to take credit for this idea, but it's hardly new. So this is a quote from 129 years ago that suggests that gauging CPR effectiveness by looking at a patient's physiologic response makes some sense. And specifically here, they're referring to the carotid pulse and the constriction of the pupils. Fast forwarding a few years, the 1980s and 1990s brought a number of animal studies and observational studies in adults that quantified the patient's physiologic response to CPR. And here we have a couple of studies of coronary perfusion pressure as a predictor of return of spontaneous circulation. On the left, data from Carl Kern's lab showing that in animals, those that failed to achieve ROSC had lower end-tidal CO2 than those who did achieve ROSC, return of spontaneous circulation, but later died, that were lower still than those that actually achieved ROSC and then went on to survive for 24 hours. On the right, that panel demonstrates data from Norm Parady's study published in JAMA in 1990, looking at adults who are in emergency departments with ongoing CPR, showing that those with end-tidal or with coronary perfusion pressure values that were less than 15 millimeters of mercury did not survive, whereas those with intermediate values between 15 and 25 sometimes did, and those with values greater than 25 millimeters of mercury were actually likely to survive. Fast forward again, another several years, and eventually these data and the data that came after it led to this 2013 American Heart Association consensus statement advocating for monitoring these parameters during CPR. We have coronary perfusion pressure greater than 20, and end-tidal CO2 values greater than 20, and diastolic blood pressure was also added and included here really as a more feasibly measured surrogate for coronary perfusion pressure, as it is that upstream pressure of the coronary arteries. In 2018, the PICU CPR study led by Bob Berg was published in Circulation, demonstrating among children with in-hospital cardiac arrest that an association of higher invasively measured diastolic blood pressures with survival. In addition to identifying this optimal cut point of 34 millimeters of mercury, there was an additional observation that needing an a priori threshold of greater than 25 millimeters of mercury in infants or greater than 30 millimeters of mercury in older children was associated with survival, giving us some potential feasible targets that we can actually use. What about end-tidal carbon dioxide? Why does it make sense to measure this during CPR? So chest compressions, of course, serve to replace the cardiac output during CPR. They generate flow to the tissues where CO2 is picked up and then brought to the lungs in a process that is again driven by chest compressions. Exhalation creates measurable CO2 that is dependent on pulmonary blood flow and thereby an indicator of CPR quality and cardiac output. So enhancing CPR quality through either better chest compressions or more drug can drive more pulmonary blood flow and thereby generate a higher end-tidal CO2 value. And a number of studies have demonstrated an association between end-tidal CO2 values with outcomes. Consistently, we've seen that values that are persistently very low are associated with poor outcomes. However, in that same multi-center cohort in which diastolic blood pressure was associated with outcomes, end-tidal CO2 actually was not. So clearly we need more work here to understand exactly how we should be using end-tidal CO2 during CPR. Notably, end-tidal CO2 can be used to potentially detect underlying ROSC, which frequently manifests as a sudden increase in end-tidal values, as you can see at the bottom of your screen. And this is potentially a means by which we can decrease the number of interruptions that we need for pulse checks. So if rather than consistently stopping CPR to assess for a pulse, if we know that it's pretty likely that we're going to see a rapid upswing in end-tidal CO2 when ROSC is actually achieved and the patient has a pulse, then perhaps we can provide higher quality CPR by decreasing interruptions en route to get there. There are, of course, limitations to both of these. So for diastolic blood pressure, we always have the caveat that pressure is not flow. So oftentimes they're correlated, but it doesn't account for resistance. So we may have reasonably high blood pressures, diastolic blood pressures, from having high SVR, systemic vascular resistance, during CPR, which may not necessarily correlate with better cardiac output. And of course, we need an invasive arterial catheter in place. We're lucky in the pediatric ICU world that about half of our patients who end up having cardiac arrests already have an invasive arterial catheter in place in observational data that we've shown here. But of course, that doesn't apply to all patients. And for end-tidal CO2, likewise, you need some sort of device in place, usually an endotracheal tube, but at least a patent airway. Vasopressors can have a variable effect on end-tidal CO2 values through vasoconstriction of the pulmonary vasculature. And of course, most of our patients with cardiac arrest in the hospital also have lung disease, and their end-tidal CO2 values will vary based on that. Nonetheless, we now do have both of these, diastolic blood pressure or coronary perfusion pressure and end-tidal CO2 association guidelines and those of other organizations throughout the world. But the real question becomes, how do we actually use it? And I'll share a couple of potential therapeutic strategies for how physiology during CPR might actually give us the answers for what we should be doing. And the first is bringing us back to the mechanics that Dr. Nadkarni had mentioned. So this study from Bobby Sutton, also here at CHOP, demonstrated an association between blood pressures and chest compression depths, expressed as a percentage of the anterior-posterior chest depth. The area highlighted here in green corresponds to 1/3 to 1/2 of the AP diameter, which is recommended by guidelines. And you can see that these compressions were more likely to generate goal blood pressures. This suggests that when blood pressures are lower than your goal, increasing depth might help achieve your goal physiology. However, in adults, this study from 2015 demonstrated substantial heterogeneity in the association between chest compression depth and blood pressure. In some patients, deeper chest compressions led to higher diastolic blood pressures, whereas in others, deeper chest compressions actually led to lower blood pressures. So overall, the jury is still out here, but this offers further evidence, I would say, that a one-size-fits-all approach may not be best. And what about chest compression rates? Is faster better physiologically? This multi-center study did not find an association between rates and diastolic blood pressures, but did demonstrate a trend towards higher systolic blood pressures when compression rates near those recommended by guidelines there in white were reached. So that shows that perhaps during CPR, we can titrate our chest compression rates to our goal blood pressures, though prospectively it's yet to be seen exactly what direction you should move in with those rates. Similarly, an adult study associated deeper chest compressions with higher end-tidal CO2 values, with the suggestion that the relationship was actually partly mediated by chest compression rate. So this story, whatever ends up being eventually, is not going to be simple. So can we actually do anything with this prospectively? And we have some colleagues down at Johns Hopkins University that say yes. So they've shown in their lab work that end-tidal CO2 can be prospectively targeted with adjustment of chest compression mechanics to drive higher end-tidal CO2 values and actually improve survival outcomes. That covers mechanics. And now what I'll suggest is that we can actually titrate cardiac arrest drugs during CPR to meet our physiologic goals. In our laboratory here at the Children's Hospital of Philadelphia, we've developed a model of hemodynamic-directed CPR in which chest compression force is titrated to systolic blood pressures. We actually titrate our vasopressors to either coronary perfusion pressure or diastolic blood pressure. When values are below that we're targeting, we give more epinephrine or vasopressin more frequently than is recommended by guidelines. But if we've achieved our goal hemodynamics, we actually may not give any drug at all. And in a number of studies over the course of the last 8 or 10 years, we've found that this strategy leads to higher systemic blood pressures during CPR, as well as improvements in survival. And the idea that different patients need different vasopressor dosing is being explored in a number of different ways. So that same group from Johns Hopkins compared animals that survived cardiac arrest to those that did not, and demonstrated that even in a group of animals that are relatively similar to one another, the diastolic blood pressure response to epinephrine was variable among animals. And whether or not they had a response, demonstrated here by a change in diastolic blood pressure after epinephrine was administered, that in and of itself was actually associated with survival. Whereas those that survived, seen there in the blue, actually were more likely to have a substantial increase in diastolic blood pressure after the administration of adrenaline or epinephrine. Similarly, in an interim analysis of a multi-center study here, we dichotomized children as either responders or non-responders based on the change in diastolic blood pressure following the first dose of epinephrine during CPR. And we demonstrated that children with at least a 5-point increase in diastolic blood pressure were 1.7 times as likely to achieve the return of spontaneous circulation. And there will be more to come on that in the next year or so. And lastly, the physiology that we observe during CPR can tell us something about the cause of the arrest itself and potentially give us clues in terms of how we can address that cause. So we know, for example, that patients with septic shock have particularly poor cardiac arrest outcomes. It shouldn't be surprising that patients with catecholamine refractory shock may not respond to catecholamines during cardiac arrest. So perhaps failure to achieve the expected blood pressure response in those patients should trigger us to consider an alternative vasopressor such as vasopressin. Similarly, low end-tidal CO2 during CPR, despite chest compression mechanics that really seem to be on target, may be suggestive of a limitation of pulmonary blood flow and consideration of pulmonary embolism as the etiology of arrest in a patient who has relevant risk factors, prompting us to go down towards a directed therapeutic such as systemic thrombolysis. Suboptimal physiology observed during CPR might also indicate pulmonary hypertension as a pathophysiologic process, which we've also shown both in our lab and in humans. And lastly, any kind of lackluster physiologic response should also give us pause regarding how optimistic we should be that we're going to actually achieve return of spontaneous circulation on that patient. And perhaps having less than ideal physiologic measures should trigger us to call for ECMO or eCPR in institutions that have that available. And lastly, Lastly, I just want to talk about what's on the horizon. So what's next? So these are a couple of not quite yet proven, but potentially useful, and I would argue very promising means of measuring physiology that are being studied now. So in recent years, there's been a huge interest in trying to understand what's happening in the brain during cardiac arrest. Cerebral near-infrared spectroscopy, or NIRS, which is commercially available and used in many settings, as well as some related technologies such as non-invasive diffuse optical monitoring, have shown great promise. In some of these studies, values during CPR have corresponded with the likelihood of achieving ROSC, or trends in the values have offered some insights into what's happening physiologically with the patient. It's still too early to know exactly how NIRS can be utilized during cardiac arrest, but I think it's certainly very promising. And lastly, pulse oximetry. So the pulse oximetry is non-invasive and widely available and used in many patients, both in the pre-hospital and hospital setting. And the actual waveform itself, not the value that we're getting in terms of the oxygen saturation, but the actual waveform itself and some of those characteristics of it may be surrogates for blood pressure or for flow, and therefore applicable to many more patients than invasive arterial blood pressure monitoring is. And in this very recently published paper, multi-center data out of China, they actually saw associations between those waveform characteristics and outcomes. Also, too early to know exactly how we should be using it during CPR, but very promising in terms of the number of patients it could potentially impact. So in conclusion, I'll offer the assertion that measuring a patient's measuring a patient's physiologic response to CPR is both feasible and potentially important. There's no perfect tool or measure, and we have to take our data in the context of the patient, their underlying physiology. Targeting underlying physiology is important, and measuring physiology can give us clues in terms of that etiology of the arrest. And prospective studies are needed, but I think some of these data can leave us assured that the future is bright. There's a lot of room for improvement, and this may be one means of getting there. So I'll turn it back over to Dr. Nadkarni, and I thank you very much for your time.
Thank you so much, Dr. Morgan.
Well, thank you, Ryan. And so now we have an understanding of what the goals are, but how are we going to get there? I think if we think forward, registries, collecting real-world data, analyzing it, getting real-world evidence, and knowledge about how clinical decisions are made and care delivered, and then reporting on the patient outcomes and experience in a feedback loop that feeds back into the guidelines and the real-world evidence that informs implementation science is probably the way forward. And with our networks, we have to think about the universe of cardiac arrests, how registries, quality improvement consortia, research collaboratives, and specific research studies can really inform and improve the quality and the evidence for what we do at the bedside, boiling it down to those brass tacks, few things that really make a difference. Over the past 5 years, we've been developing the PD Rescue Network, which has 60 sites in 12 countries, 40 IRB approved, and 35 active entering data. And you can learn more about this at the pdrescue.org website. But this collaborative has started to address each aspect of the pre-arrest care, intra-arrest care, and post-resuscitation care with a focus on preventing cardiac arrests. And then after cardiac arrest with excellent resuscitation, really focusing on preparing and achieving the goal-directed targets for post-cardiac arrest care management: temperature, blood pressure, oxygen, carbon dioxide, glucose, pH, electrolytes, fluids, and neural-directed care with EEG and treatment of seizures. And then debriefing and following those therapies and the patients and families through longer-term outcome to look at cognitive, physical function and quality of life. What we have identified is that checklists and electronic medical record risk screening can improve the detection and preparation for cardiac arrest. A checklist was effective in identifying high-risk patients and their bedside providers with a number needed to train of approximately 6, which is a reasonable number in order to overtrain for that rare cardiac arrest event that needs expert care. Hot debriefings, understanding, reflecting immediately after cardiac arrest was occurring in half of the participants in the PD Rescue Network. And the content of the discussion and the coordination and clinical standards were frequently identified as areas of both positive and opportunities for improvement. This has been crystallized into an overlying study of the CPR coach, successful in simulation and improving the adherence to get with the guidelines, and now being deployed across 10 different centers in order to identify whether the ergonomics of resuscitation, the training of CPR coaches, can improve the implementation of those few evidence-based interventions that seem to make a difference. We're exploring and collecting data on shocks. We recognize that about 30% of the shocks delivered are actually delivered for non-shockable rhythms in the in-hospital ICU environment, and that the amplitude spectral array or the coarseness of fibrillation may be an important factor both in children and in adults to help guide timing of defibrillation. We are examining the pauses and finding an association of worse survival outcomes with longer duration pauses. And in fact, every 5-second increase in longest pause duration in patients who went on to receive eCPR or ECMO resulted or was associated with worse survival and neurologic outcome. So pauses and duration of pauses may make a real difference. We are starting to collect and explore how the placement of the hands on the chest, in this case, the placement of the hands compressing the aortic outlet valve, and with a very small adjustment of the hand position, now relieving the outflow tract and making the compressions much more effective. How can we learn to adjust and personalize the care, as Ryan was telling us? And how can we collect data on those natural experiments like abdominal-only CPR, lateral chest compression CPR, or prone CPR that are occurring in this COVID environment or in the cardiac ICU setting, and capture the hemodynamics and the outcomes to try to understand if there are certain patients who might benefit from different types of CPR. By video recording in our resuscitation bays of the future and displaying the video laryngoscopy, the ultrasound, and the chest compression depth to the room using video software, we can now start to create resuscitation bays of the future that support resuscitation practice and debriefing. And better yet, by wearing eye-tracking glasses as we do in our resuscitation bays for neonatology, we can start to understand what experts and novices are looking at during the resuscitation, how they look from the patient to the monitor to the patient to the monitor, or whether they just look at the monitor or look at the patient, and whether that impacts the flow in the room, how we can adjust how we stand around the bedside in order to better have ergonomics and communication that matters. We can collect during resuscitation the chest compression qualities, the mattress characteristics, and start to model and use informatics and engineering to improve the devices and the coaching that we deliver. And in fact, we can turn the focus from the patient to the provider and start to understand the effects of posture on fatigue, posture on quality and depth of chest compressions, and understand the timing of switchovers, which also will not likely be a uniform duration, but perhaps provider dependent. And perhaps we can develop new tools, new interfaces, new displays that will facilitate resuscitation in situational awareness. We're in search of adjuncts, circumferential chest compression, load distributing bands, active compression and decompression impedance threshold devices, and ECMO. How can we make this man and machine instead of man versus machine? As Ryan was saying, how in the future can we start to put together specific etiology-based therapies that can make a difference early in the resuscitation when we still have a chance to reverse the mitochondrial dysfunction and shock that results from hypoxia, ischemia, and reperfusion injury? Whether it's the brain, whether it's shock, whether it's cardiac arrest or sepsis, the final common pathways can be addressed with a cocktail in the future. Our chain of survival needs to focus on those things that improve survival and survivorship, quality of life, not just amount of lives saved. And by preventing cardiac arrest, we will be saving lives, families, and survivorship. We mentioned that registries are quite important in collecting real-world experience. But now our registries are starting to collaterally collect data on our mock codes so that our performance in training can be married to our performance in real life and vice versa. And we can start to understand what we need to do differently in training that will impact real performance. And how can we move this from the in-hospital, highly resourced environments out of the hospital to the lay rescuer to improve survival outcomes? Our journey of survival and the chain of survival was expanded in 2010 with a focus on post-cardiac arrest care, and yet again in 2020 with a focus on survivorship and recovery. How will we get there? By early aggressive post-cardiac arrest care in the early and intermediate phases, we can improve survival outcomes. But in the recovery and rehabilitation phases, we can start to stratify and neuroprognosticate. We can identify, stratify injury severity, assess organs, and titrate therapies in the early phases, and then understand with prognostic indicators, biomarkers, and imaging how better to personalize and identify those prognostic factors that will allow us to limit and withdraw life-sustaining therapies when appropriate and prepare families and enhance recovery and rehabilitation. By making post-cardiac arrest care checklists, by creating pathways in our electronic medical records to facilitate appropriate care with appropriate clinical goals, to design order sets and implement and to create post-cardiac arrest teams that are knowledgeable and can support teams that are less experienced. How can we create a chain of survival that allows an assessment and support of physical and functional outcomes, cognitive and communication outcomes, and true neurologic outcomes and quality of life? In the future, improve surveillance, early detection, rapid response, team performance, monitoring and coaching, mechanical and ECMO support, post-resuscitation care, and long-term follow-up focused on quality of life with quality reviews and debriefing are the way forward. And we are moving in that direction. Our challenges for knowledge discovery, processing, and transfer are large, but not insurmountable if we work together. Our formula for survival is getting ever stronger with a product of medical science, education, and local implementation. Thank you for your attention. I look forward to your questions.
Thank you so much, Dr. Vinay and Dr. Morgan. I will have a couple of questions in order to start this couple of minutes that we have. Let me pose the first one. Have we changed CPR practice during COVID? That will be the first one. And the second one is, what is the status on TTM cooling after cardiac arrest? And the third one, should we use epinephrine infusion titrated during rather than bolus? So let's get it.
Well, thank you, Jaime. It's really a great pleasure to be here with you live, to be talking, and I think it's a really great question. So first, let's just start with COVID, and I think Jaime Fernandez Sarmiento really initiated a lot of these questions that are great questions. So in our hospital now, 99% of the healthcare providers are immunized and 70% are boosted. So we have a situation where the risk to the provider has decreased quite a bit for COVID. During the earlier phases, when this was not the case, we were very concerned about COVID resuscitation. So one, we made sure that we limited the number of people responding. We continued to provide RCP for the patients, and we halted eCPR for COVID positive patients for a period of about 6 months. But after we achieved the immunization goals for the providers and had systems to deal with it, we restarted even eCPR. Our survival outcomes are about 30% low for COVID positive or PUI patients compared to non-COVID suspected patients. But the differences that we did were, one, always have a HEPA filter on the expiratory limb of bag mask ventilation or the ventilator. And number two, we intubated early with the most expert person in the room performing the intubation to try to minimize the amount of aerosol generating the. Jaime, do you want to translate, or do you want to move just in English?
No, continue, and let's go on for a second question.
So the second question is a really difficult one, really important and kind of unanswered for targeted temperature management. Do we recommend cooling after cardiac arrest? So short answer is yes, we recommend cooling, but cooling to avoid a temperature greater than 37.5. We do not want to see fever or high temperature. That usually requires active cooling. Whether we should cool from 36 degrees or 33 degrees targets, this is unclear. And to speak to that, I put together, let me just perhaps see if I can share one additional slide with you. And Jaime, you have to tell me if this is projecting or not.
Yes. I am seeing you perfectly. Yeah. Okay.
You're seeing this slide now.
Yes.
So what I would say is that the discussion and the controversy over targeted temperature management to hypothermia versus normothermia continues. In the early phases in 2002, we had adult studies suggesting benefit of cooling after out-of-hospital adult cardiac arrest. In 2005, we had several studies in neonates with hypoxic ischemic encephalopathy that suggested a benefit to cooling to 33 degrees for newborns who were born with hypoxic ischemic encephalopathy of mild to moderate degree. But these are not the patients we're talking about in pediatrics generally. In the TTM1 trial, there was benefit to cooling without adverse consequences in adult out-of-hospital cardiac arrest. More than 90% had cardiac arrest due to arrhythmia, sudden cardiac arrest in adults, coronary artery disease. Then in 2015 and 17, we had two trials, out-of-hospital and in-hospital THAPCA in pediatric patients, which did not demonstrate significant benefit in long-term outcome comparing 33 degrees with 36.8 degrees. But there was a possibly clinically important difference in the out-of-hospital group of a more than 8% improvement in survival with intact neurologic outcome. In the TTM2 trial, in the Hyperion trial, recently published in adult out-of-hospital and in-hospital cardiac arrest of respiratory origin. These were PEA and asystole arrest, not cardiac origin, 90%. there was benefit to cooling with no increased adverse events. But in the most recent adult out-of-hospital cardiac arrest trial, TTM2, with cooling versus a hypothermia versus normothermia, there was no significant benefit, but there was increased risk of arrhythmia in the cooled group. So the current recommendation just released 2 days ago by ILCOR was cool to keep the temperature less than 37.5 degrees, but there's insufficient evidence in children to dictate whether we cool to 36 or whether we cool to 33. Finally, I think, Jaime, you asked, what about a continuous infusion of epinephrine after cardiac arrest rather than boluses of epinephrine? And although there have not been studies that have compared this, on a theoretical basis, this makes a lot of sense, because in the low cardiac output state of CPR, when we give big boluses of epinephrine, we see after cardiac arrest a very high blood pressure, hypertension, which may be very risky for perfusion and for strain on the heart. And so a continuous infusion to effect to a diastolic blood pressure of greater than 25 in infants, greater than 30 in children, may be a better strategy, but has simply not been tested in clinical trials, to my knowledge.
Okay, Vinay, thank you so much. Lorena, I don't see any more questions. Do you have any? Or any in the floor would like to ask any question? Lorena?
Doctor, perdón, ¿me repite por favor?
Si hay alguna otra pregunta más que alguien quiere hacer.
No vemos ninguna otra pregunta aquí en el chat, doctor.
Pueden hacer en español si quieren, o si no, pues doy los agradecimientos y terminamos el webinar. Jaime. Okay, Vinay, so it seems that we don't have any more questions as of now. I would like to thank you in the name of the Nadkarni organization and our pediatric hospital here. And also to Dr. Morgan, thank you so much for an excellent conference. Hope to see you again and hope that we can crystallize that dream of us of having a good time here in Bogota. I will work on that, okay?
That sounds wonderful. I look forward to the day, and thank you so much for the invitation and the pleasure of presenting.
Thank you, Vinay. Bye-bye.
Bye-bye.
Thank you, everyone, for assisting to this excellent webinar. Buenas tardes a todos.